Thank you and welcome to tonight's webinar, Managing and Minimising the Harm of Non-Prescription Steroids and Other Performance Enhancing Drugs. I'm so sorry that we are running late this evening. We've had some last minute connection issues, but they have been sorted now. So thank you so much for bearing with us. My name is Dana Harris from the PHN Education team, and I'll be facilitating tonight's session. I'd like to start by acknowledging the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. Before I introduce our speakers for tonight, there are a few things that I'd like to let you know. As attendees, your camera is automatically disabled and your microphone will automatically be muted. If you have any questions or would like to make any comments during the presentation, please send those all via the question box and they will be answered at the end of this evening's presentation. An evaluation will come directly to you after this session. We would be very grateful if you could fill this out so we can make sure that our sessions meet your needs and expectations. Lastly, participants in this webinar will be able to register for the Echo Hub, which is a free peer support learning, live interactive, online and evidence-based model of practice, which places healthcare providers from diverse settings in direct contact with subject matter experts. Part of this session will involve active thinking and contribution as we discuss de-identify cases. And this session is planned to run on the 22nd of February at 7 p.m. You will automatically receive an invitation to this after tonight's event. It is my great pleasure tonight to introduce our three speakers, Dr. Katinka van der Ven, Dr. Esther Hahn, and Kay Stanton. Firstly, we have speaking Dr. Katinka van der Ven. She's a senior lecturer at the Centre of Rural Criminology, University of New England, and visiting fellow at the Drugs Policy Modelling Program, University of New South Wales. Katinka has over 10 years of research experience in the field of performance-enhancing drugs and alcohol and other drugs more broadly. She has led the development of the GP Performance Enhancing Drug Guide to Harm Minimisation. Katinka is also the chief and editor of Performance Enhancing and Health and the directive of Human Enhancement Drugs Network. Thank you for being with us tonight, Katinka. I'll now hand it over to you.
Thanks so much. I've just turned my camera off for the presentation in the hopes that my internet connection is a bit better. It doesn't just show my screen. And my apologies, everyone. It's technical difficulties on my end. So I'm now trying to share my screen. Dana, can you confirm that you can see my slides?
Not yet. Let me try one more time. There you go.
Oh, give me 1 second. Yeah, it should work. It is showing. Let me enlarge it.
No, not as yet.
Okay, can you?
What I can do is I can share it for you and you can read through them if you like.
Is it working now?
No, it's not.
So it shows, yeah, it keeps pausing on my end. Every time I say showing screen, it like automatically stops stop and clicks pause.
Okay, what I can do is I can share my screen.
Yep.
Excellent, and then you will be able to talk through them.
Yeah, the problem is that I don't see your screen at the moment. I don't know where my slides are
Now
up
you
to.
should be able to see my screen.
Otherwise, perhaps unfortunately we'll have to start with Esther, so we can continue this, and then hopefully things will be sorted on my end after Esther has given her presentation.
Might be better to put me first, I think.
Okay, let's put Kay first. I apologise, everybody. Thank you so much for bearing with us. We will start this evening with Kay Stanton. She's respected in Victoria and interstate as a leader in the field of steroid education. Kay began bodybuilding 30 years ago, which quickly led to competing successfully in various bodybuilding events. For the past 25 years, Kay has been employed as a steroid educator with your community health. Kay is sought after as a valuable resource and speaker on steroid education. Kay delivers advice and information to community groups, NSP groups, and individual bodybuilders, and more recently, school groups. Kay has been a contributor to the McFarlane Burnett Blood Study Project, the Quick Doctor's Reference Guide, and other assorted research projects. Thank you so much for being with us today, Kay. I will hand it over to you now. Fingers crossed this works. I've now. Excellent. We can see your screen. Thank you so much, Kay.
Okay. I can't. Okay. I haven't got my screen on. Okay, it's not coming up on my end.
What is it coming up with? Just
nothing. I've just got faces still.
Okay, so just up in the top corner, you should be able to minimize us and see your PowerPoint, because we can see your PowerPoint.
There's nothing.
Okay.
No. So if I do that, okay,
You
got
can't
it.
see yours. Okay, excellent.
Sorry, everybody. I've got it now. Okay. Right, as you can see, what I'm about to talk about is the outreach model that I run and have been running now for 25 years, the steroid education program. Okay. Now my slides aren't moving. Oh, here we go. Okay. As you can see, the program started in '96. When it started, it was the way it actually was kicked off was because a bodybuilder was coming into your community health, then known as Darebin Community Health, and he was actually even though he was short, he was quite a large bodybuilder doing the amateur comps, which at the time I was involved in as well. And what he was doing, he was accessing the NSP there, and the manager at the time decided to actually pull him aside and talk to him about his use and other things. And with that, she realised that, and this is true to this day as well, that most bodybuilders, one, don't see themselves as, or steroid users, should I say, don't see themselves as drug users. They also don't have any or minimal knowledge on bloodborne viruses, and also they have no idea of the risk of infection, the risk of bloodborne virus due to injecting procedures. Now, with saying that, the risk in terms of injecting, even though it's intramuscular, is quite high. A lot of the time there is a lot of blood lost from the injection sites, and because they don't see themselves as drug users, they'll just wipe that and carry on and make up something else for themselves or the next guy. So it's in that term that they actually run risk. They don't share needles as such anymore. Many years ago that might have been so, but not so much now. So it's more the blood contact and surfaces and things like that, but also sharing vials and those type of things. It started off with a 2-day pilot program, and with that, just in the northern suburbs of near Reservoir there, and then it ended up they wanted a female, which is where I came into it, which was probably about 6 months later, to see if we could access more females. Now, it doesn't matter whether it's male or female, they're all very secretive about what they do. They don't want people to know that they're not natural for many reasons. One, the stigma attached to it. So it sort of flows on from there that their confidentiality is really at the most. And I think part of the reason this program has been so successful is I go out of my way to keep their confidentiality a must. So with that, it went to 3 days. Now, then after that, the original guy decided he didn't want to do it anymore. Part of the reason was confidentiality, because this program tends to point the finger at yourself. But I actually seen a big need in the program, not just for females, but males as well, because there was a lot of risky stuff that went on and lack of knowledge of. So it then went from 3 days to 4 days to 5 days, but we went from northern suburbs to Melbourne metropolitan to statewide. But also eventually in time it went interstate, where I do a lot of work with workers interstate in terms of NSPs and research and stuff like that, such as tonight. But also I have a lot of clients because I do talks interstate, and I've done them in every state quite a few times. My card gets sort of shifted around a lot, so I get a lot of clients that will ring from Queensland and Sydney and whatever, Tasmania and those type of places, and just for information and to ask questions that they want to know and things like that. So as you can see, as I said earlier, it's an outreach program, and basically my office is my car, and even with saying that, in the mornings I load up with injecting equipment for clients that I'm going to meet throughout the day, and in any given day I'll do 100 Ks to over 300 Ks, depends where and how many clients and where they are in Melbourne. So it can get quite lengthy. So with that, because I still pretty much live the lifestyle of training and eating properly, and that I actually take a car full of food containers and everything. All my food prep is done, so I'm still eating the right things and not cheating along the way. Yeah, so the only thing my car hasn't got is a toilet, but Macca's is usually good for that anyway. So I meet people. It can be anywhere around Melbourne, basically. I can meet them at gyms that allow, and when I say that, there's not that many gyms that are quite easygoing with the program. A lot of them think that it stigmatizes their gym, so they won't have me in there or any written information as such. And even with saying that, most gyms, and I can pretty much say at least 95% of gyms would have some sort of steroid users in there at any one time, because steroid use is gone through the roof for a long time now, that it's just getting more and more. It's becoming a drug of choice. But you know, you got the hardcore gyms, you know, basically that you'll see the really big men and women coming out of those ones, and they're the more the competitive people, whether they're doing like powerlifting or bodybuilding competitions and that. But you also got all your mainstream gyms anyway, and a lot of them will have steroid users in there. Maybe not as big as the full-on hardcore guys, but a lot of men and women, they might just have the nice muscle-toned what I call Calvin Klein look with the six pack, and that they can still be using steroids, and they're just not as big, and they can go under the radar and claim to be natural when they're not. So if it's not in the gyms, I can meet them outside of gyms, and I suppose this program's worked a lot on word of mouth, so clients will pass my number on and things like that. But some of the gyms that do have me, they're usually lovely. They'll offer me a cuppa even when I go in there, and have a talk about what's going on in their world. But you got outside of the gyms, I can meet them. I can meet them at Macca's, as I said earlier, which gives me a chance for a toilet break. You also got work sites, cafes, anywhere they feel safe, even outside their own premises. You know, and you'll get ones that will say, "Oh, this is my home address, but meet me 3 doors down," so you know no one sees you coming and things like that. So it works all different ways. It can be a quick, easy exchange. It can go from, you know, a quick 5 minutes to 1.5 hours of sitting there talking about things such as the dosages they're using, injection risks to bloodborne viruses and keeping themselves safe there, to injection sites and infections, and knowing, you know, what an infection looks like and how to treat it, and you know, basically to get help from the doctor with antibiotics. Training, it even gets into, you know, a healthy diet and training tips and things like that. So there's lots of things we discuss. More of it's probably about the compounds they're using and how much, and these days the dosages that are out there are quite crazy. But also I work in and out of NSPs in Melbourne as well, but even interstate too. A lot of the time they'll ring me, and some of the staff, whether it's Melbourne or interstate, they can ring me and ask questions if they've had questions after people have left that they need to know. Or in terms of Melbourne, I just drop in and I leave cards and pamphlets and things, but also sit and have a good old, you know, talk with the staff there. And a lot of conversation comes up about clients they've seen and how to interact with them and things like that. So it's sort of a win-win situation. You know, we can sort of make both our programs work really well. And also doctor referrals. Now here, we need lots of doctors here. We've only got one who gets bombarded, and with COVID, half the time they've had to stop taking new clients. And it's a really big, probably problem that, you know, steroid users don't want to go to doctors anyway. And when it does get where they have to, I mean, the reasons they don't want to is things like they don't want their, you know, if they're in a health fund, they don't want them finding out that they're using steroids in case they have a health problem down the track and they look back and blame it on the steroids that they've been using, even if it's got nothing to do with that. So they worry about that. They worry about work finding out whether they're using steroids. They worry about family members finding out. Also, it's illegal as well, so it's really hard to get them in there. So we need doctors on board that are going to be, I suppose this is the wrong way to put it, but steroid friendly in terms of how you treat them, because a lot of doctors, and I get this from clients all the time, a lot of doctors will say, just stop putting that stuff in your system. Well, it's not that black and white. And, you know, and as we go on, you'll know why, with all the body image addiction that goes on, and they can't just stop and they need help with that. And in terms of that, I'd like to actually discuss with doctors how that can be, because at the moment, if they have to come off, it's just stop point blank. And with low testosterone, and sometimes, you know, basically shutting down. They're tired, lethargic, they've got depression, you know, they're losing everything they know. It's really hard for them to cope, and a lot of the time they don't cope and they end up going back on. So I think there's, you know, maybe things like HCG or things like that. I don't know, but I need to discuss it with a doctor, because bodybuilders use those type of things all the time to spur back, you know, their testes to working and that. I don't know what the solution is, but I'd like to talk to doctors about trying to find something to actually help in that sense. Okay, so who uses? As you can see, we've got models and everything. We've got PTs, you know, personal trainers. A lot of personal trainers will use so that they, you know, they find that if they're looking really good and buffed and whatever, that they'll get more clients and things like that. So it's sort of a catch-22 with them, but also, you know, I shouldn't say this, but some of them are also dealing as well. So there's, you know, there's more incentive to look really good as well, because you know, it actually helps them in that way that I just said. Weekend warrior. So you got, you know, people, you know, that ride even you know, push bikes. Like in Melbourne, they go down Frankston and that down the highway, and a lot of them are using steroids just for endurance and also getting better response out of themselves and things like that. But then you've got the local football player who which I've had a few clients that over the years, you know, they're trying to keep up with the young ones, so they'll do a cycle while they're doing the weekend local football, just trying to keep up with the younger blokes. You got the armed forces, you've got even the gay community, you know, for dance parties and things like that. It's part of their wardrobe, but even people in general, you know, it's part of their wardrobe to look good when they're out at these dance parties and stuff. But also, I suppose the biggest increase is people with body image. So just, you know, wanting to look a certain way, and they use steroids to do that. Okay, now some of the influences. Now I've actually sat and I've thought about this, and social media is, I would say, is a huge increase in people wanting to use steroids. They see images, and I'm a culprit myself. I look at female bodybuilders on there, and I follow a few of them. And you know, if I wasn't as old as what I am now, I'd probably want to look more like them and probably try to get there, I suppose. But you know, there's some awesome bodybuilders, female and male, out there, and they use social media to and this is how people think they should look. You know, they want to look like that. That's what they see a lot of. So social media is a huge influence on how people want to look and see themselves. And in terms of that, it actually encourages body image and body image addiction. Now, in terms of that, you know, they want to get a certain way, and steroids is a way to get there, and they just keep using, and they can't, the thing is, they can't see, when it gets really bad, they can't see that they're actually quite huge people, and like in terms of muscle structure and that, and they're even lean, and it's sort of like it's sort of like similar to anorexia, but reversed. It's, they don't see themselves as big, so they keep using lots of chemicals, and their whole life is dedicated around training, eating, trying to get this perfect body that even though they've got it, they can't see it. But they also cover themselves up. You know, they wear big t-shirt, big wind sheeters and hoodies and things like that, because they feel like that, one, their body isn't meeting the standard that they want, and they have this obscure vision of themselves mentally in terms of, you know, the body image, but also they think that their body fat levels are really high, and they're not. They're actually quite lean and could step onto a competition stage without a problem in the world. So it encourages them to just keep on doing more and more and more. Now, as for age groups, we've got, now there's an increase in every age group possible. So you've got teenagers, you've got the middle age group, which always been there, and you've got people in their 40s and above. Again, social media and body image is a big draw with teenagers. And yes, as at the start of this, I did my first high school talk, which I've been trying to do for years, and trying to get into schools is as hard as, I don't know, it's just impossible. But we did it, and I had 110 students in a uni lecture theatre, and it went really well, and they were really interested. So they got to hear a lot of the negative stuff that they wouldn't hear if they were standing in front of someone trying to sell them this stuff. Now, in terms of teenagers, their hormones are as high as they'll ever be, so they can quite easily change their body anyway, as we know. But also, just with a healthy diet and training and proper training and that, they could make huge differences without putting themselves at risk of permanent side effects and addiction to steroids. And with the social media, a lot of those things you're looking at are basically being enhanced anyway as well, even though, you know, they might be bodybuilders, but they, you know, mess around with it as other people do. So anyway, so teenagers are an increasing population now. In between's always been there. Female has gone up, steroid use has gone up through the roof. And in terms of over 40s, well, you know, the reason they start at that late age is, you know, their body's not the best and they're feeling a bit crappy, and the kids are off their hands, and you know, they want to change all this, so they get into the gym, and eventually they get hooked up with someone who says, oh, you know, give this a go, it'll make you, you know, look a lot better and change, you know, a lot quicker than what you're doing. And really, it doesn't matter which group you look at. If they try this and they don't get an infection or any health problems, everything they get out of it is positive, absolutely positive. So I also, you know, I get people that say they just want to try it once. Well, unless anything bad happens, like I just said, they're going to actually end up doing more courses than that, because everything's so positive. They've changed everything. They feel better in themselves. They're confident. People are commenting. They're changing this whole body that and the person they're known as. So they take on a different identity. So with the over 40s, you know, I have guys saying to me, I feel like I'm 21 now. My sex drive's up. I get out of bed. My joints aren't hurting. I look better. I've lost weight. I put on size. Everything's great, you know. So there's sort of it's a bit hard to go back when everything's so positive. Now, as for cultures, I've seen lots of different cultures anyway, but there's been a really big increase with my program in the Indian culture using, I don't know if people know Melbourne, but Craigieburn, Alert, and then over at Tarnegi and Tarneet and Truganini, all these places, I've got so many Indian clients now, it's not funny. So there's an increase in that, and the only reason I can put that down is I have a friend that I've known for years, and he went back to India, and he was looked at like God and looked after and looked up to like God, he reckons, and you know, he was having a whale of a time because he was something special over there. So I think that's got something to do with it. Okay, black market. Okay, these are some of the things that people can get, no named, like no labeled at all. And then you've got ones with written things on them. You've got photocopy. This is all on the black market. Now, people will still use these because it's the only thing they can get at the time. So they take the risk. Now, the problem is, because of the substandard way they're actually packed and everything, you don't know whether there's bacteria in it. You also don't know whether it's the chemical that you actually want. So for a female, that would be really important to make sure whatever you ask for is in there. If that's a testosterone and that's not what she was after, she could end up with lots of side effects, as we know. And regardless, even with the milder things, women can end up with side effects. But so it's really, you know, important that but it's the risk of bacteria in that as well. So these are just some of the ones. I've got a huge kit, so these are just briefly some of the things that I have in my kit that are around it, you know, in suburbia. But even if they're picture perfect, you don't know whether there's bacteria. They're just putting more time to actually produce them. So it doesn't guarantee you that there's no bacteria in the bottle, or that it is what it is, or there's nothing in there that shouldn't be in there. But people, as I said, will use it because that's all they can get. So this is the risk of infections. Now, I go through with them the risk of infection if they get an infection. So a site starts to get red hot, swollen, as you can see. They need antibiotics straight away. So as talking to doctors and that, if they've got some sort of infection, to hassle them about what they're doing is probably, not what they need to hear, but they need help. And it will clear up very quickly, but if not, they have to get it surgically lanced and drained. And as we know, it can take away a lot of muscle tissue if it's damaged. So that's what the risk is to black market stuff, which nowadays there's so more black market stuff. There's more people making it because of the money that's involved in the usage, because it's increased so much. Dosages, and this is where they've changed. The dosage, the bottles that we're looking at before, years ago when I was first competing in that, you'd have things that were 50 milligrams per mil, 75, 100, 150. Now there's something, most of them are 200, 250, 300. There's a 400 test and there's a 500. Now, just because the concentration is more per mil, people aren't cutting down their dosages, so they're still having even more. So again, health problems, side effects, the whole lot. Normally, 10 weeks on a time for cycle time. So time on was usually 10 to 12 weeks maximum, with, basically rule of thumb is have that off to let everything go back to normal. But now there's a culture which is blast and cruise, and a lot of young guys are doing this, but this has been around for a little while now, where they do these massive high dosages, and they don't just go for 10 weeks though, they go for about 20 weeks and some are longer. And then, but they're really excessive dosages, and then they bring it down. Instead of having time off, they bring it down and just do this cruise for a while, and then they go back up. And this is what they do long term. Now, I had this young guy who was on 3 years doing this, and he was too frightened to come off because he's created this look and this body and what he's now known for. And he was too frightened to actually come off. The other day, I had a guy that had been on 10 years, but 6 permanent, and he's getting lumps where he's injecting probably through scarring tissue, which what we sort of got it down to. But I talked him into going getting some blood tests done and things like that. Now, the dangers of insulin, as we know, you can hypo. It's always been in bodybuilding, with more with pros using it and stuff like that. And, they work all their carbs and everything around it, and their sugars and everything, to try and keep from hypoing. But we're saying that, there's a professional bodybuilder who died at 26, and he was on the Olympia stage a few years back, and that was through insulin. But also in New South Wales, there was a young personal trainer that died in one of the gyms there, and Katinga and I were both on the coroner inquest to that. So, but now it seems to have increased more with amateurs using it, but also females. And I've spoken to a few females lately that are using it, and the reason they're using it is because they're trying to cut down some of the anabolic for side effects, but they're using growth and insulin. And people use insulin because the belief of speeding up nutrients into their muscles after their training, so they'll grow quicker, repair and grow quicker. So, the females are now taking the risk of that as well. Okay, now just quickly, this is okay, some of the different stages of female. Now these are a couple of years old. So the first two bring up muscle structure a bit more on those two. The last two are pretty much as they do compete these days. What I'm saying with this though, there's so many females that are using, and they're passing themselves off as natural. Most the last two probably can't get away with that so much, but the first two, they've actually gone up more in muscular shape. Now the last comp that I went to, there was more females competitors than males, which was like, I don't think I've ever seen that happen before. But most females now are tampering with steroids to one degree or another. And of course, saying they're natural, because it's worse for a female to say that they're using something. So that just gives you an idea. Now this, this is just a comparison of two top pro bodybuilders on the IFBB stage. Now, this is only a couple of years old. So it shows you the size of the females these days are equivalent to the male, and they're massive, like massive units, male and female. And I suppose a quick fact, a quick little fact here is if the guy there won the first division in the not the Arnold, the Olympia, he would get these days, and it's pretty much similar when years ago, $400,000 for first place. The female there would get 50,000, and even though they train just as hard, they do all the same things, except for I would say, and this is coming from a female point of view, you put yourself at more risk of side effects and health issues, more so than a male. So it's actually quite interesting. So that's about it. I think that would end my talk, except for probably some quick harm reduction tips that I would go through with clients would be more isn't better. They believe the more you use, the bigger you'll get. And really, you'll just get more side effects and health problems, but they don't need to use the excessive amounts that they are at the moment. Proper needle sizes, because a lot of them try and get the smallest needle possible. So I go through them about the risk of infection and the fact that it's got to be a deep intramuscular shot. Signs and risk of infection, what to look forward for in that, so they're aware. Injecting each other and how to keep themselves safe from bloodborne viruses if one was to have that. Yeah, and I suppose the importance of getting blood checks if they can get to a doctor, because a lot of them won't want to. Okay, thank you. That's me. Thank you for listening. Yeah.
Thank you so much, Kay. I really, really appreciate it. We now will try Katinka again. If you do have any questions, pop them in the question box and we will answer them at the end of the session. I'm now going to share my screen so that we can start Katinka's presentation. We're going to try that this might be the best way to go. So give me 2 moments now.
Can you hear me?
Yes, we can hear you, Katinka. Excellent. So
that's already one victory.
Can you see my screen?
Yes, that's perfect. Great.
Excellent.
So
All right, I'll hand it over to you. Take it away.
Thank you. And thank you, Dana, also for the lovely introduction. And I really apologize to everyone for the technical difficulties. There's honestly nothing more frustrating than, technology not working when you need it to. So basically today I'm gonna, ideally we would have started with this presentation because I'm just gonna give some background information regarding prevalence, what, why, and how. And just really quickly, I've done a lot of research in this area for over 10 years I have over 10 years of research experience in this field of performance and image enhancing drugs and also alcohol and other drugs more broadly. I've led the development of the GP PEAT Guide to Harmonization that relatively recently was released, and I'll show to you that also in a second that you can freely access as well. And I've done a lot of research on the use, supply of steroids and other enhancement drugs, and particularly also looking at how we can improve access to healthcare services for people who are using steroids for non-medical reasons. So Dana, could you go to the next slide? Oh, it is showing everything now, including my notes, Dana. Not sure what happened. Can you go to learning aim and outcomes? Thank you. So basically what I want to talk about today is to have a general understanding of the non-prescribed use of steroids and other PEDs. And the learning outcomes today are to identify commonly used PEDs and other use in the community. And I'm using the acronym PEDs, which stands for Performance and Image Enhancing Drugs. To understand the prevalence of enhancement drugs, reasons for use, adverse effects, and commonly used substances. And also to understand mode of action and how they're administered. So Dana, can you please go to the next slide? So most of the information I'm presenting today is based on the Guide to Harmonization for Patients Using Non-Prescribed Steroids and Other Enhancement Drugs, which I developed together with several colleagues, including also Dr. Esther Hen and Kay Stanton, who are here today. And this guide is freely available on the Sydney North Health Network website, and it covers aspects like red flags, backgrounds, assessments, management tips, referral sources, and it also has a couple of recorded webinars in there as well. I have to say that this was originally, of course, developed targeting, doctors in New South Wales. So even though most of the information is quite general and applicable, to anyone, the referral sources are, for example, more so geared towards referral sources that are located in New South Wales. Dana, could you go to the next slide? So performance and image enhancing drugs are drugs used to enhance the appearance of a person or to improve their physical capabilities such as strength and endurance. And this term represents a wide range of substances, but the oldest and largest group used are non-prescribed anabolic androgenic steroids, and they actually have been used probably since the late 1940s. And the term PED in the academic community is generally used because people who use non-prescribed steroids usually use other enhancement substances as well. So that's why usually that acronym is used to talk about all the different types of substances that people potentially will use. Dana, would you mind going to my next slide? So what types of PEDs are typically used? So the main substance used, at least by men, as I said, is usually anabolic androgenic steroids, which is typically used in combination with other enhancement drugs. So people who use non-prescribed steroids often use other types of enhancement drugs and other illicit substances for to achieve augmented effects, to minimize adverse effects of steroid use, and also for recreational purposes. And the table on the right in this slide just shows some examples of substances used. So for example, tamoxifen is used to prevent gynecomastia, human growth hormones are used for its anabolic effects and strength, and ephedrine is used to increase energy and to boost training and to enhance weight loss. And for more information on this, I would like to refer to the guide, which has a much more comprehensive overview of the different types of enhancement drugs that are being used and also for what reasons. Next slide, please. So, Kay also, of course, showed already some examples of how products can look like, but I just wanted to show you that there's basically three different types. So here you have an example of stanozolol, which is a water-based injectable steroid. You have an oil-based steroid like sustanon, and then you also have something like dianabol, which is an oral steroid. And it does seem that oral steroids are more popular amongst younger consumers. But a particular issue with oral steroids is that they are more toxic to the liver. Next slide, please. So let's have a little bit of a look at the prevalence rate in Australia and what is actually going on. So when we look at population studies, we see that the use of enhancement drugs for non-medical reasons is relatively low, but there are indications that it's growing. So for example, the National Drug Strategy Household Survey shows, despite the overall number being small, that there's a growing trend in non-medical steroid use in the previous decade. So only 0.3% of people had done so in their lifetime from between 2001 to 2017, but the proportion rose to 0.6% by 2016 and again increased to 0.8% by 2019. But these numbers are much higher when we're looking at specifically high risk as an environment like bodybuilding gyms. So for example, one Australian study showed that 51% of male gym users use non-prescribed steroids and other PEDs. This is of course very targeted and does not really give a good overview of what is happening in the general population. And there are some methodological issues going on with some of these population studies. So the true prevalence is not really known at the moment, is a bit unknown in Australia. But as I said, there are indicators that steroid use and other enhancement drugs is rapidly growing, particularly in the time period of 2005 to 2015. So for example, if you look at this figure, that comes from the Australian Needle Syringe Program Survey National Data Report, which is a mouthful, which shows a significant increase in PEDs as last injected drugs over the period of 2010-2014, being 7%, followed by a small decline in 21 to 4%. And I included New South Wales here because I thought potentially there would be more doctors today attending who are located in New South Wales. But actually New South Wales is one of the states where the last PED injected is higher than the national average, with numbers remaining stable at between 10 and 12%. Although it was really interesting to see that in 2021, this all of a sudden dropped to 2%. The reason, is a bit unclear. My suspicion is that this has to do with COVID, and we know that this survey is done at needle syringe program, so it could simply be that during this time, less steroid users were accessing less needle syringe programs during the COVID period, and therefore also less people participated in this research. Next slide, please. So why do people use non-prescribed steroids? So let's first start talking a little bit about what age do people start. I mean, Kay already talked about this a little bit as well. But when we look at research, we see that between the ages of 20 and 24 years of age, we see that between the ages of 20 and 24 years of age is usually a typical age that people start using. We have seen reports of people starting as young as 14, but it is really rare. And then we also have this group of older men that Kay mentioned that as well, that are 40 and over, who are using non-prescribed steroids mainly for anti-aging purposes, as opposed to, for example, increase muscle mass. So although motivations for using steroids and other enhancement drugs vary, we do see that the most common reported reason is for aesthetic purposes. So changing one's body image or for cosmetic purposes. However, other reported motivations that we see is for recreational and competitive bodybuilding, to enhance sport performance, to enhance occupational performance. So think, for example, of security staff or military personnel who uses steroids to become stronger, hormone replacement therapy, to retain youthfulness, for anti-aging purposes, and also to aid injury, pain, anxiety, and to increase confidence. Next slide, please. So again, Kate asked a little bit about this, but when engaging with patients who use steroids, it might be good to be aware of some of these common terminologies used by people who are using steroids and other enhancement drugs. So a common term that you probably will hear is that steroids are used in what is called cycles. So steroids are mostly used in cycles with a duration between 6 to 18 weeks, termed as an on cycle, and this is then usually followed by a similar period of a steroid-free training termed the off cycle. And the rationale behind the strategy is to gain muscle mass during an on cycle, allowing the body to recover between cycles. So the idea is that you minimize the risk of adverse effects and by taking these breaks, and then maximize the effects on steroids when you start using again. However, we are seeing increasingly that people are using steroids either take a very short break or no break at all. which is what Kay also mentioned, is called the blast and cruise approach. So this blast and cruise approach is the continuous use of steroids involving a higher dose, the blast, for a set period, which is then followed by a lower dose, the cruise, for a set period. So this rotation can continue for an extended period, up to several years, and due to the lack of an off cycle, this approach may potentially increase health risks associated with testicular shutdown. And then finally, something that you also might commonly hear is the use of post-cycle therapy, and this is sometimes also one of the reasons why patients potentially will come in. So the primary concern of steroid use is the potential to suppress natural testosterone production. So in response, some consumers will use other pharmaceutical substances during or after stopping their use to basically help restart their natural testosterone production. There is, however, limited empirical evidence that these, post-cycle therapy approaches really are effective. Next slide, please. So how do people administer non-prescribed steroids? So although steroids are mainly either injected or orally taken, depending on the product, and it is common to see people using a mixture of both injectable and oral products. So for example, in one global study involving more than 1,000 men who use steroids, around 30% reported both injectables and oral steroids in their lifetime. And both routes of administration carry risks, either via the injecting process, as Kay also highlighted. So for example, one Australian study showed that 56% of people who injected steroid reported experiencing at least one injecting related problem in their lifetime, such as abscesses, scarring, and hard lumps and swelling of arms and legs. But then there's also the risk of liver dysfunction, as I mentioned earlier, caused by using oral products. So when injected, steroids are generally administered intramuscularly, typically in the glutes, outer thigh or shoulder. And I would recommend, again, having a look at the PED guide, as there's several resources for both health professionals and patients in there who discuss the safest techniques for reducing steroid injecting related harm. And there's also a video regarding safer injecting practices as well. Next slide, please. So there is a wide range of health harms that are related to the substances themselves, such as the physical and psychological harms related to the modes of administration, as we already mentioned, and also, as there's other harms like, as Kay mentioned, the quality of black market steroids. So adverse effects that have been well established in relation to steroid use are cardiovascular disease, cognitive deficiencies, and steroid dependence and depression. So in my work with health professionals, something that is often noted as a reason for which patients present are symptoms related to steroid withdrawal, such as decreased libido, being tired, feeling depressed, which is often related to hypogonadism, which Dr. Ezehan will come back to in her presentation. It is, however, important to remember that not everybody will experience adverse effects and that many are reversible when stopped. For example, hair loss and acne, and that also some people will experience pleasurable effects, otherwise they wouldn't be using these substances, of course. So for examples of pleasurable effects that have been reported are increased body image satisfaction, increased sex drive, increased confidence, and increased muscularity. Someone is also, more or less likely to develop adverse effects depending on the duration of their use, the amount used, the type of substance used, and so on. So, for example, steroids can impact your cholesterol, which doesn't necessarily carry an immediate threat, but however, long-term disturbances may increase the risk of cardiovascular incidents. And when we then think of that blast and cruise approach that I mentioned earlier, we see that this is the group that is more likely to report adverse effects because they're not stopping their use. And we particularly see that younger consumers are adopting this blast and cruise approach. And outside of not stopping, we also see that younger users tend to use higher quantities, more different steroids at the same time, also different types of enhancement drugs while they're using substances. And this, of course, is concerning, as this will increase the risk of developing adverse effects. Next slide, please. So I just wanted to talk a little bit about steroid dependence. So in terms of steroid dependence, it is important to note that research is pointing out that there's basically two pathways into dependence. So dependence is characterized by long-term use of steroids, often for many years, and also frequently in spite of side effects. And steroid dependence may be a part of a larger pattern of dependence of enhancement drugs involving other substances in addition to steroids, like human growth hormone, insulin, and so on. And physical appearance concerns are uniquely associated with the severity of steroid dependence and depression in steroid consumers. So there appears to be a body image pathway, to call it that, into dependence, in which the individual basically becomes preoccupied that he or she will lose muscle size when he stops taking steroids, and becomes reluctant to stop even for a short interval. And this is referred to often also as muscle dysmorphia, or as the media likes to call it, bigorexia, in which a person is very muscular and trained, but actually sees himself as very small. And another way is when consumers stop using steroids and their natural testosterone production stays suppressed and doesn't start up naturally. And this can sometimes really take months, sometimes even years, and in some cases it doesn't return. Anyway, but the medical term, as I also mentioned, it related to this is hypogonadism, but it can lead to a loss of sex drive, being tired, in some cases serious depression. And instead of going to a GP, what consumers will do is just simply, start a new cycle to avoid these feelings. And this seems to be a more common pathway into dependence as opposed to the body image pathway. And I also want to note, and I think that's really important, that research and my work with GPs generally see little consumers that don't really necessarily meet the diagnosis for the body image disorder. So it is good to be mindful of this, that potentially can be an issue, but for many patients it isn't necessarily an issue. And I think sometimes it's just too over-focused that people try to focus on the body image issue, despite actually there being other concerns or other things going on. So it's important to remember that most people who use steroids don't necessarily have a body image disorder. But what we do see, though, is that people who do have a body image disorder, that they are at increased risk of using steroids. I hope that made sense. So just quickly, next slide. I just want to summarize what I have been talking about. So basically my take-home messages are, although population studies show that PEDS uses in Australia is relatively low, there are other indications that it is potentially growing. The most common type of enhancement drugs is steroids. Other PEDS are often used to achieve augmented effects, minimize adverse effects of steroid use and for recreational purposes. Steroids are mainly injected or taken orally. Steroids are used by both younger and older people, and motivations for use vary, but the main driver is for aesthetic purposes. You can go to my last slide, which is basically thank you for listening to my presentation. And as I said, we'll do questions at the end, but I'm happy if you have any questions after this webinar, which also can be in relation to supply or the quality of black markets, or you want me to send educational materials, feel free to contact me. Happy to assist in whatever way I can. Thank you.
Excellent. There we go. Thank you so much for that, Katinka. Now I will hand over to Dr. Hahn. We have got Dr. Esther Hahn is a GP in the Northern Beaches of Sydney, a drug and alcohol specialist at Royal North Shore Hospital, and a clinical lecturer at University of Sydney in the discipline of addiction medicine, a Northern Clinical School Faculty of Medicine and Health. She treats patients using performance and image-enhancing drugs, and was part of Sydney's North Health Network team that put together the GP PIEDS Guide to Harm Minimisation. So we'll hand it over to you now, Esther.
Thanks very much, Tina. Okay. All right. And can you see my first slide?
Yes, we sure can. Thank you, Esther.
Great. Okay. So hi everyone. Thanks for being with us this evening and giving up your Wednesday night. So I guess I've got a few aims from this presentation. The first is, you know, I think, you know, what do I want you to think, feel, and do after my presentation? So I guess one of the things is just want you to think about asking patients about, yeah, if they're using any of these substances, and we'll have a little bit of a chat about how to ask these questions, yeah, in a sensitive, kind of non-judgmental way. I want you to feel that, yeah, you've got the skills to be able to do that. And then after this, yeah, hopefully you'll be able to go away and start doing this. So common presentations that I've seen and also from the literature around this PEDS use. So one of the common presentations, as Kay and Katinka have also alluded to, is just adverse side effects from using PEDS, and that would be things like abscesses. And I had this gentleman who came in, and he was complaining of a sore buttocks, and you know, had a look and looked like he had an abscess, and I asked him, and he was really surprised that you know, that I suspected that he was using steroids. So it could be things like also acne related to testosterone use. It could be things like hair loss related, you know, to using. Also people wanting to, you know, help with gynecomastia or other bad side effects that they get from using these drugs. Even things like I've been referred in the drug and alcohol clinic from a GP who, yeah, tested his patient's bloods, and this patient had quite a lot of blood derangement. So he had a high hematocrit level. The creatinine was high, but again, when we're testing patients who often have larger muscle mass and they might be taking a lot of protein powders, we actually need to do say recalculation of their renal function, and I did a Cockcroft formula calculation, and it ended up being that his renal function, kind of for his, you know, mass and everything, was normal. And there are some other blood tests that are non-Medicare rebatable, that the cystatin C test, which is about $50–60 to get a more accurate measure of renal function in patients with high muscle mass. And yeah, this gentleman also had deranged liver function, high cholesterol, and so he had quite a few blood derangements. And so yeah, then we had to repeat the blood tests, and yeah, we look at, you know, referring if they need a venesection, if they've got a high hematocrit level, organising that, obviously keeping on monitoring their liver function tests and stopping any other offending drugs, but also advising patients to stop if they're drinking alcohol, maybe to kind of be mindful how much of their drinking, other things that could be impacting on their liver function, and treating high cholesterol if necessary. So yeah, cellulitis and other skin infections that can come as a result. Then another common presentation is, yeah, the hypogonadism. So just the refresher back to the hypothalamic pituitary axis, there's a negative feedback loop. And because people are using, when they're using, you know, the exogenous non-prescribed steroids, testosterone, they're using these at super physiological doses, sometimes hundreds, sometimes even thousands, kind of what the physiological doses are. So there's huge negative reinforcement back to the hypothalamus. And so it essentially shuts down testosterone production. And that can take a while to kick back again, including, you know, one of the things that I talk to patients about, especially kind of patients who are, you know, younger, who may be wanting to have kids, is if you want to have kids, it can take 1 or 2 years sometimes for your body's production to restart again, in order for you to be able to, yeah, then be able to conceive a child. And I had a gentleman in his early 30s who came and saw me, and yeah, he and his partner were trying to conceive, and I ended up, yeah, referring them to a fertility specialist to get some help, because his testosterone levels were still yeah, quite suppressed from his previous using. And yeah, definitely the testosterone kind of withdrawal symptoms that we see, and that can vary kind of how long it lasts for. For some of my patients, like things like depression, the low libido, erectile dysfunction, you know, fatigue, that you know, for some of them it lasts a few weeks and then they kind of feel better again. So not, you know, not super long, but for others it can last for, you know, much longer. And as Kay said, yeah, that just kind of makes them, yeah, go back onto a cycle again. I've got another group of patients who are proactively want to get their blood test monitored when, before they start using, or kind of whilst they're using, and once they're kind of off cycle. And so, you know, that's great. You know, that patient, I'm like, great, let's engage this patient in some harm reduction, and we can address things as they come up, especially any adverse health consequences. The other kind of main presentation is people coming specifically to ask if I can prescribe PCT drugs, so the post-psychotherapy drugs. So I had a gentleman come in, and he described quite profound hypogonadism, kind of steroid withdrawal symptoms, and he came asking if I could prescribe some testosterone replacement. Now, we've got obviously restrictions around kind of testosterone replacement. Needs to initially be generally started by a specialist like an endocrinologist, and so I would refer to some of the endocrinologists in the area that I've worked with. But this gentleman also was asking for things like clomiphene and tamoxifen. And so look, with clomiphene, again, there are restrictions around who can actually prescribe that. So it seems to be only like, fertility kind of specialists and, endocrinologists that can prescribe some of these more specialized drugs. So just, based on, obviously you guys are in New South Wales primarily, but jurisdiction to jurisdiction, you just have to check which, what the local kind of state laws are around prescribing. So when I assess for, PEDS use, I guess the first thing is just to reassure confidentiality. And that's because patients using these drugs, are concerned about, other people finding out, whether it be, partner or third party insurers, things like that. And also around kind of the laws around this. And so I just reassure them, I'm not the police, I'm not here to W in, I only care about your health issues. I reassure them that we've got doctor-patient confidentiality, but also the limits to that confidentiality. So, if I'm seriously concerned about their safety, for example, if they told me they were going to hurt themselves, harm themselves, or, commit suicide, then I might need to break confidentiality in that instance. So I reassure them about confidentiality. And then I just make it a routine part of my drug and alcohol history taking. So after I've asked about like alcohol and smoking, and then I ask about other illicit drugs, then I might just ask, do you use anything? Do you use or take anything to help out with your workouts or muscle gain? And can you tell me about any supplements you're using, including any pills, powders, or injectables? And again, part of this, I just say, look, these are routine questions I'd ask everybody just to check if there's any other health related issues that I need to be aware of. And when we ask about these things and trying to take a non-judgmental approach, that's also having a balanced approach, because acknowledging that these, if they are using or if they're wanting to use, that these substances do have benefits, including some of the increased gains that they're hoping for, and not just disregarding that and just presenting all the negatives about using, actually giving a bit of a balanced view. So as kind of alluded to previously, remember, it may not be that obvious who is using steroids, because people are using for all different purposes, and I definitely have had kind of middle-aged men, older men using more for anti-aging purposes. And we have that, is it like the elixir of youth? And I had a gentleman who was in his 50s that I'd gotten to know. He actually, I met him first in our opioid treatment clinic. He was on methadone. He developed a opioid use disorder, associated with his kind of chronic pain syndrome. And that's because when he was in his 20s, like he started using steroids in his early teens. Then in his 20s, he went on to do bodybuilding professionally, kind of won awards and everything, and then kind of kept using, but he was, training through the pain, using testosterone to train through the pain. He had ignored a lot of his kind of musculoskeletal injuries and ended up developing a chronic pain syndrome. And so now he's in his 50s and kind of still using, but not as much as he used to. But we just kind of talked about, when do we kind of let aging take place, like just natural aging? And we developed a bit of a relationship, and he started using less. and then, yeah, the young guy, you know, and it's not, obviously the young guy on the right doesn't look incredibly muscular. So more that lean muscular physique. And definitely I'm seeing more teenage, like high school students, late high school students, and a lot of them tend to be from private boys' schools. And I do this GPs in Schools program that our Northern Sydney Primary Health Network has started, so where GPs in the local area get to go out to some of the high schools and the kids and pretty much just answer any of their questions. They can write anonymous questions and about anything health related, you know, sex, drugs, rock and roll, you know, mental health, gender diversity, whatever it is. And a lot of the students are asking about steroid use now, so it's getting more common, as well as vaping. And then we've got the women, as Kay alluded to as well. So more women are using, and definitely on the northern beaches where kind of I've been working, definitely seeing more women, especially there's a lot of that obviously wanting to, look fit and healthy. They're living around the beach. And these people don't think of themselves as sick people needing a doctor, because they look healthy, they're fit, they're training. So they don't often want to come to a doctor, but yeah, when we do have them in our door, it's just something that we can screen for. So what are the red flags? So definitely used by a young person, less than 21 years old, and that's because there's a high risk of irreversible complications, even with just short-term use. So things like stunting of growth, affecting fertility. And for women as well, again, it's the same, that there's a high risk of irreversible complications. Comorbidities, so things like if the patient has cardiovascular disease, high blood pressure, high cholesterol, or the polycythemia, that can obviously increase the risk of like clots and things if they're using steroids, if they continue to use. And then you've got things like the red flags, like people who do develop the hypogonadism after use, which may be persistent, because obviously that high risk of relapse to using testosterone and requires treatment, and you know, perhaps some testosterone replacement in conjunction with like an endocrinologist. Patients who have a high PSA level, so if there's a risk that the patient has prostate cancer, then extra testosterone might increase the growth of that cancer. So anybody with any abnormal examination findings, so things like the high blood pressure, things like, or blood results that are abnormal, so liver and kidney abnormalities, as we talked about previously. And anybody with any kind of mental health issues, so whether it be depression, anxiety, schizophrenia, or bipolar disorder, and or other substance use, that could exacerbate when they are using testosterone. So testosterone and some of the other performance and image enhancing drugs can lead itself to either worsening depression or aggression, mania, and obviously we want to reduce those kind of or be aware that is more risky for a patient who's got that background. So some of the basic investigations that we do, so if somebody comes to me and this is that they haven't started using anything yet, then I might just do this panel of investigations just to see what their baseline is before they go on. Once they're on the on cycle, things like testosterone obviously are going to be sky high. And so I wouldn't necessarily check that, but I would check, you know, all the other blood tests that are listed there. And then again, when they're off cycle, and typically at least 6 weeks off cycle, preferably 12 weeks off cycle, before you retest things like the hormones, the LH, the FSH, the testosterone, and estradiol and sex hormone binding globulin. And so motivational strategies for each stage of change. So I think the first thing to identify is when the patient walks in the room after you have had the chat with them, what stage of change are they in? Are they in the pre-contemplative stage? So that they're currently using, or they're about to use, but they really, they're going to use, they don't want to change that behavior at all. And so in that case, really, I just focus on engaging the patient. Let's proactively monitor your blood tests, providing some basic education and around harm reduction in particular. And yeah, let's monitor your bloods, let's check for bloodborne viruses, let's get you, you know, make sure that you've got access to clean needles and syringes. I might refer them to my local needle exchange to get some education about safe injecting. If they're in that contemplative phase where they're a bit ambivalent, yeah, there are good reasons to change and there are good reasons to stay the same. And I find that often it's their partner, you know, there's relationship issues there. They might be getting a little bit more aggressive and their partner's kind of, you know, wanting them to stop using. Then this is where I would focus a little bit more about kind of motivational interviewing, so reflecting back to them some of their own reasons for wanting to change and helping them to kind of tip the scales in favor of them making a change. And if they're prepared to, you know, make that change, then yeah, again, I would provide encouragement, support, regular reviews, again, keeping on monitoring their blood test and yeah, referring to other specialists as needed, if they need a psychologist or a mental health specialist, if they need an endocrinologist, referring to them. And then when they're in the action phase, again, just continuing to review them, encourage them, support them through that change. So those are the different kind of strategies that we can use at different stages of change. Obviously with maintenance, yeah, it's about kind of continuing that relationship. But also a lot of it is about finding out what the context like of use is. And as Kay talked about, you know, the social media influences, and definitely with the young people that I'm seeing who are using, you know, yeah, these are the people that they're following. But also, there's also been links with, you know, things like childhood trauma, and especially physical abuse or sexual abuse, and then people kind of wanting to get big to kind of, you know, not feel scared again, because that obviously when they were younger they didn't kind of have much control or power, and when they get older, you know, to be big and intimidating so that they're never put in that vulnerable situation again. And I've definitely had some patients who that was their history, that they'd had that childhood trauma. So kind of finding out a little bit more about their history as they kind of, as you engage them and you have these ongoing conversations with patients, and it starts to make sense, this is where this kind of substance use is fitting into the context of the person's wider life and their background. And if they relapse back to use, again, relapse, you know, we consider part of the stages of change kind of within addiction and things like that. And so, you know, helping that patient and kind of if they want to get back out of the lapse, you know, what did they learn from that lapse? You know, it's a lesson. What things are they going to do differently next time so they don't lapse back into using? And how can we support them in that, both, yeah, with medically and psychologically? So some of the basic kind of management tips that we talk about is meeting the person at their stage of change. And doctors, and I confess myself included, we're generally always at action, and our patients are way back at pre-contemplative or contemplative. So to actually kind of slow ourselves down and think, okay, where's my patient? Okay, how can I go back and meet them at where they're at? Because it's our job to meet them where they're at, not our job to drag them to where we are. And I think of it as a long-term approach. If you put the patient offside in the, you know, the first encounter, they're not going to come back and they're not going to engage with a healthcare professional. So I'm trying to play the long game with my patients in how can I make an environment that this person will kind of feel safe enough to come back and see me. And again, around the harm reduction, if they get bad side effects or bad health effects, for them to know that I'm here to address that, they're not going to get in trouble, that they can go to the hospital if needed, you know, that there's not going to be any legal ramifications from that. And so providing education, and they've done surveys of people using steroids, and what they want is credible, balanced information. And one of the resources in the patient resources section of the GP guide on the Sydney North Health Network website is this pocket guide to steroids. And it's a PDF that you can either, you know, email to patients or print off for patients. And it's got some really good, useful information about what gauge needle to use, also about the different steroids, the different testosterone, and kind of typical doses that people would be using. For this is more male-centric because a lot of the information. Obviously, it has been kind of male dominated for a while, but yeah, the typical doses that male users would use. And so it just gives some like balanced medical scientific information that patients can feel reassured, and also that we can feel reassured that they're not just kind of reading some rubbish off the internet. Harm reduction. So again, yeah, getting them clean access to clean needles and syringes, syringe disposable needle disposal units, and that's where, yeah, I refer to the needle syringe program. And also on the Exchange Supplies website, they can order online. I know some of my patients would do that. So treat their underlying health issues. So if they come in with acne as a result of their steroid use, I had a GP last week, actually. I was doing some lunchtime education and asking, oh, but if you're treating the complications from steroid use, aren't you condoning it? And I just liken it to something like diabetes. So how many times do we go and ask our patients to exercise and eat good diets and, for their diabetes management, and they come back in, and it's hard to make those sustained behavioral lifestyle changes. So they come back in and their HbA1c levels are still high. So we put them on medication to treat the complications of their diabetes, the high blood sugar levels, so that they don't cause more complications like retinopathy and nephropathy. So I treat the complications when they come in through the door. So things like gynecomastia, so prescribing tamoxifen, which is off-label, but yeah, definitely, up-to-date guidelines suggest tamoxifen, 10 to 20 milligrams for a few months for treatment of gynecomastia. And if that doesn't work, then referral onto surgeons to treat the gynecomastia if that's one of the adverse effects that the patient has. Refer as needed to other specialists, as I said before. So it might be fertility, it might be endocrinology, it might be psychology. And just a tip about elite athletes. So most of us on our GP softwares have that tick box if you're using best practice or med director, where you can check if that person is an elite athlete. And so that cross-references with the database, just so that if we prescribe anything that is in violation with the anti-doping rules for elite athletes, then it'll come, flag as a warning on our system, similar to if we're trying to prescribe something for somebody who's breastfeeding, so that it just shows up on the system, so that we GPs can also, any healthcare professional treating elite athletes can also be subject to anti-doping rule violations. So we just need to make sure that, yeah, we're not prescribing anything that could get that person, yeah, a violation. So that wraps up my talk. Thanks everybody for your attention.
Thank you so much for that. I know that I found that very interesting, and I hope that everybody on the line did too. Once again, I'd like to apologise for the tech issues that we did have to start with. There are a few questions in the chat box which we might run through very quickly. If the questions we don't get a chance to answer them this evening, we will get our panel to answer them offline and send emails through with the answers. The first question that we have is was from earlier on during Kay's presentation, and the question is, what's the impact of IM steroid injections on blood glucose levels?
Sorry, what was the question? What was the impact on intramuscular?
IM steroids injections on blood glucose levels.
I don't know, I'm not a doctor.
Yeah. So that might be, maybe could I throw it to one of the other panel members?
Esther, do you know the answer to that?
Yeah, so look, I don't think there's any immediate reaction on blood glucose levels in the immediate. Was it in regards to kind of was a question about insulin, or?
It was about blood glucose levels, but then the next question that we've also had underneath it from the same person is there much use of insulin for building muscle mass? So they link together, I would believe.
Yeah, okay, yeah, so I guess, to back Esther up, I guess in that sense, it's always hard with these questions because we automatically think of steroids, but Yeah, so insulin is very complicated. So Esther can probably talk about a bit more about how it actually affects the body. But the problem is with insulin, we do see its use. There currently is no research indicating how widely it's being used. But it is, you know, when we think of enhancement substances, these insulin is one of the enhancement substances that is more problematic because it can potentially be something that can lead to direct harm. Because as we know, you know, if you inject it and you go in a diabetic coma, you know, that potentially can also lead to a loss of life. And that was also that court case that Kay was referring to. So there was a young boy who was attending a 24/7 gym. He, in addition to steroids, was also using insulin. He injected himself on the toilet with insulin, but he wasn't discovered. And he, of course, went into diabetic coma. He wasn't discovered until the next day when it basically was too late, and he unfortunately passed away. So we don't know to what extent it is widely used. We do know that it happens, and we do know that it is very concerning because of the direct harms that can follow from it. So Esther, do you want to add anything to that?
So no, I mean, yeah, the main reason I guess people are using insulin is to build strength because it's anabolic and to burn fat, and also for weight loss purposes. So that's, I guess, the main theory behind why people are using insulin. Yeah, for for this purpose. Yeah.
Okay, from my opinion on that, they use it for, as I said earlier, to speed up the nutrients into their muscles for recovery. Now the problem is most people using steroids, their insulin level is normal, so the chances of hypo is quite high, and it is getting more prevalent in use. And as I said, females are now starting to use it as well. So, and with, I mean, we used to have an insulin pamphlet out years ago, and with the death of that PT in New South Wales, we updated it and reissued it, and basically it covers the dangers of using it, but if you are, the signs of a hypo and how to reverse that, you know, by using quick-acting sugars, and there's a whole pile of different quick-acting sugars and things like that. But also to tell a mate, you know, that you're using it, so people know that it's insulin use that's involved. Yeah, so.
Excellent. And the follow-up from that was just that they've said that I'm a diabetes educator, so see a lot of hypoglycemia from prescribed steroids. So that was the context of that question, I believe. Now, there was a question that I believe has been answered as well. So what we will do tonight, if that's okay with everybody, I am aware that we have run a little bit over time. So for that reason, what we might do, if there are any other questions, put them in the chat box and we'll have them answered offline. Alternatively, we do have our echo session coming up, which is our peer support case-based discussion. So you can come along with a case study and we can work through the case study with our panel. I've sent everybody an email in regards to that session, how to register, and I have already done that this evening. So thank you so much to our panel for being with us tonight, and also for logging on. Once again, we do apologise for any tech issues and the delay, but we really thank you for sticking with us. We do also have a resource list that will be sent out tomorrow to everybody online that our panel has put together. Other than that, we look forward to seeing you at the Echo and at other events in the future. Thank you. We just have people logging off. If we can just stick around for a moment more.
How do we get everybody's faces up?
Thank you. Dana, would you like us to stay online for a little bit?
Could we stay online for a moment more? Sorry, I'm just making sure that the majority of our participants have left.
No worries.
Sorry, anybody who hasn't left, I'm just going in and dismissing. Sorry about the wait. All right. Okay, all gone. Thank you so much, everybody. That was actually, it was a great session. It turned out okay. People stuck with us, and look, we just apologize. Sometimes tech things are out of our control, right? We did everything. Everybody on the line knows that we've done as much as we possibly can to make.
I'm just turning my camera off. Hopes that the internet is a bit better.
Look, we can't fix it. We've done it. We apologized for it. I think everybody was interacting. Really looking forward to our survey results coming back. Looking forward to receiving some invitations for our next part. Sorry. There are some really heated questions. There was one.
So how was my connection? Could you hear me clearly during the presentation? Yes. I was really worried that I was actually.
Yep, we did. Yep. We could hear you in the end. It did work. They're doing with what I'm doing. So the next time we use a platform, it'll be Zoom.
Because now my connection is super bad.
Look, but the next one will be Zoom, and we'll practice beforehand. So we might get you on a little bit earlier next time, just to make sure.
Sounds good.
But I'll be. There are a couple of questions, so I'll email those out to you. And if we could get them sort of answered as a group.
What was a heated?
And I'll be. Oh, they're not so much heated. They're just long. And so I'll just get you. I'll send them to you, and we can answer them afterwards. I'll be in contact with you over maybe the next week to prepare for next week. In regards to payment, I'll make sure that I send through payment forms tomorrow for you to get the invoice forms, so you can send those back to me, and we can organise to get you paid for your time. Thank you so much for coming online this evening and sticking with me, even though we had a few issues. I'll chat to you, in the coming week, and make sure that we're all good for the next one.
Great.
Thank you so much.
Just a quick question.
Yeah.
Did a lot of people drop off? Because we had in the end 35 people, I think. Did we have more in the beginning? I was just wondering whether the technical.
There were a few people who did log off, but that's okay. We had 30 on the line, and 72 registered. So it'll be interesting to see how many people have. You could tell the engagement. People were listening. People were asking questions. I had a few people emailing me at the same time, saying this, like, I'm sorry that you guys had some tech issues, but it's a really great session. So that's fantastic. We've already got some great feedback. We'll be able to watch it after the fact, and we'll be able to re-engage with them at the Echo, hopefully.
Great.
Perfect.
Excellent.
Thank you so much.
Thank you.
Thank you. Thanks for all your help.
Great evening. Thanks so much.
See you,
and Esther, we need you down in Melbourne.
Oh, thanks, Kay. Yeah.
We really do.
Yeah.
Bye.